Hello, everyone, and welcome back to Echo Asthma Bootcamp. My name is Ashley. I am your facilitator. I'm joined by my coordinators, Rachel and Tabitha, and our wonderful hub team, Dr. Mandeep, Jassal, Andrea Jensen, certified asthma educator, and Aaron Sutton, licensed clinical social worker. Now, Aaron is new to this group, so I would love if he could introduce himself to everyone.
Absolutely. Ashley, good to see you as well. Thank you for having me. My name is Aaron Sutton. I am a licensed clinical social worker trained as a psychotherapist, and I am the behavioral health faculty at Abington Family Medicine, which is a family medicine residency program outside of Philadelphia, Pennsylvania.
Very happy to have you here today to talk about shared decision-making techniques. Alrighty, so very exciting. Today we're going to talk about shared decision-making. This presentation will be presented by Dr. Kerr.
Hello, everybody. Welcome to session 5 of the Echo Asthma program. Today, we'll talk about shared decision-making in severe asthma. My name is Dr. Sucharita Kerr. I'm an assistant professor at Tufts University School of Medicine in Boston and an adult pulmonologist with an interest in asthma at Tufts Medical Center. So what is shared decision-making? Shared decision-making involves really two participants. It's the physician or the healthcare provider and the patient, where mutual sharing of information occurs, including the patient's values and preferences, to build consensus about favored treatment that ultimately culminates in an agreed action plan. It has been shown to improve clinical outcomes as well as quality of life by educating patients and empowering them to be really actively involved in their own health. It's often thought about as a two-way communication where the clinician discusses what the patient has, the diagnosis, what the potential treatment options are, what the risks or the benefits may be for that treatment options, and what they would expect once the patient starts that pathway of the treatment. On the other side, the patient will discuss the values, what's important to them, what they prefer, what their opinions are about certain treatments or procedures, and what their lifestyle may be. And then together, taking both aspects of this into account, a shared decision is made. Now, it's important to note that this decision may happen in one visit, or it may take a series of visits for this to happen. And it's really important to also note that this is not necessarily a give and take, but really a discussion, a collaboration between the clinician as well as the patient. I'd like to highlight this with one example. So after discussing with the patient, the physician may realize that they may choose to substitute a current prescription that the patient has for a less expensive medication, mainly because cost is a big barrier as to why the patient is not necessarily adherent with the medication. And it may be that the replacement that the clinician prescribes may be less effective, but actually a drug that patient can actually take because the patient can now afford the drug. And so really it's having these empathetic conversations with the patients that allows us to really understand what their values and preferences are, that ultimately gets the patients engaged as well as empowered in their treatment plan. And there are many benefits to shared decision-making model. It is shown in studies to improve adherence to medication by the patient. It improves patients as well as in terms of kids' parent satisfaction. There's less indecision from a patient standpoint because now they're much better informed. There's improved patient knowledge. There's improved patient-provider communication. Clinically, there's better asthma control, higher quality of life scores, lower asthma-related healthcare visits, and overall healthcare costs. There certainly are some challenges, and so studies have shown that providers perceive that shared decision-making takes too much time, when in fact, the studies have also shown that consultation time increased by only about 3 minutes or less when a shared decision aid was used. So there are certain factors that we can use to actually allow us to help to come to a valid shared decision-making visit. There may be perception that the provider is already involving patients in decision-making, But studies show that clinicians elicit patient agendas in only a third, about 36% of encounters. And even when they do, on an average, clinicians interrupt the patient as soon as 11 seconds, not allowing them to speak further. And after asking the patients to express their concerns, this study showed that clinicians listened to them only for about 18 to 23 seconds before interrupting. And so there's certainly opportunity to do better for our patients. Clinicians also may incorrectly assume that their patients want and expect their healthcare provider to make decisions for them. In reality, most patients desire their own input and want to provide their own input for the healthcare decisions that's going to affect them at the end of the day. And so if you look at the GINA guidelines, they recommend that the long-term goals for asthma management are, one, to assure good control of their symptoms and to allow maintaining normal activity levels. And second is to minimize the risk of asthma-related death, exacerbations, persistent airflow limitation, and side effects, which is true for anything. Our role for patients is to make them feel better, make them live longer if we can. And so, but GINA guidelines also recommend that it's really important to elicit the patient's own goals regarding their asthma, as they may differ from conventional medical goals. And that shared goals for asthma management can be achieved in various ways, bearing in mind differing healthcare systems, what medications are available, as well as cultural, as well as personal preferences. Patients may have preference for IV or subcutaneous administration. 4 out of the 5 FDA-approved biologics are administered subcutaneously, and one of them, rosalizumab, has an IV administration route. This is a cross-sectional study. It's an observational study of 150 patients attending an outpatient pulmonary clinic. These patients showed that about 18% had a preference for IV versus over 80% preferred the subcutaneous route. These patients felt that subcutaneous was more convenient than IV, but the belief was not associated with the higher likelihood for preferring a subcutaneous administration, interestingly. Also, IV formulations were thought to be more likely associated with a quicker and a more effective drug action, procedural safety, and medical oversight and social support. However, this may not necessarily be true. Thus, the preference was guided by partially misleading beliefs, which ultimately may generate wrong expectations that in turn may affect treatment satisfaction and adherence down the line. And so as clinicians, we should really be aware of the possibility of this cognitive bias among our patients in order to be able to provide them with accurate information and for health education. Beliefs towards convenience and efficacy of drugs with different routes of administration should be formally elicited and discussed during that doctor-patient or clinician-patient interaction to achieve informed decision-making. And so there are things that can potentially be done to also reduce injection-associated anxiety. There have been evidence-based methods for reducing needle fear, and these include exposure therapy, including instruction, modeling, and targeting of catastrophic thoughts to reduce the fear in adults, and CBT, or behavioral therapy, or cognitive behavioral therapy, hypnosis, and breathing interventions may also help reduce adolescent distress. Now, there may be various factors that should be considered, both on the patient's side as well as the physician's side. And so let's bring this shared decision back to thinking about how it impacts patients who we are considering biologics for, or patients with severe asthma who we want to start on biologics or who we are recommending biologics. So this was a study that was published more recently last year that asked patients as well as physicians what was important to them in this context of starting a biologic for severe asthma. And for patients, it was, not surprisingly, out-of-pocket costs, the mode of administration, how long it would take to achieve peak effect, so the time of onset to efficacy, and what administration setting it was. While on the other side for physicians, it was more important to know the mode of administration, certainly the time of onset of efficacy, how long it's going to take to get my patient feeling better, the dosing interval of frequency, as well as a lot of questions around insurance reimbursement as well as access. Both groups, patients as well as physicians, preferred less frequent administrations. For example, every 8 weeks compared to every 4 weeks or every 2 weeks. And also subcutaneous over intravenous administration of biologics. And so certainly the Chest Foundation and the Allergy and the Asthma Network have provided us with decision aids that I would certainly encourage you to review and look at. The website is right there at the lower right corner, and use it to your advantage and to your patient's advantage when you're having these conversations with the patients. And that's really where personalized medicine comes in. We have lots of good treatments for asthma as well as severe asthma. A lot of these are based on the patient's particular phenotype and endotype, but it's really combining the available targeted treatment for severe asthma along with this shared decision communication model that allows us to really personalize medicine in patients with severe asthma. Thank you for listening, and we'll open this up for some question and answers.
Thank you, everyone. Thank you, Dr. Care, of course. So we're going to open up the floor to Dr. Jassal and our hub team for their key takeaways from this lecture.
So I think the core part that I want to get at is the patient standpoint, because most of us know pretty well what providers would prefer, but the patient takeaways are really important and can't be underestimated. So the first, in terms of costs, so getting a good assessment of the out-of-pocket costs is always a good thing to know generally ahead of time what generally a drug may mean for patients, both in terms of the direct costs, in terms of what they may have to pay right out, or even the indirect costs, like the lost days of work they may have to undertake to get an injection, for example. And then in terms of trying to assess those patient outcomes are also really important. And Dr. Kerr had mentioned this in the terms of decision aids to help speed up a visit, but also make that visit count. So we all have different approaches. We all have different types of asthma control types of questionnaires we use. You can find the one that works best for you, be it the asthma control test, the control questionnaire, or another form. All of them are very important. And then quality of life questionnaires could also be important. If you don't feel like employing some of those quality of life, well, figure out the domains that really matter to your patients. So ask questions about school, work, life, activities, the things that actually matter to them and how that could be impacted in terms of starting up a biologic or not starting up a biologic. So all of that is really important. And I strongly encourage incorporating those patient-reported outcomes or those decision aids into your care practices. And then she mentioned drug administration. Now things are evolving in pediatrics whereby self-injection options are possible now with Xolair. So in terms of pediatrics, we don't have to worry about the intravenous option for children. So we do now have subcutaneous options that are now available for all of our patients. Now, will they avail of it? Will they want it? Or do they prefer to have it in the office setting? Those are all part of that shared decision-making conversations. And then in terms of the injection-associated anxiety, there's quite a bit built around pediatrics, especially for patients that aren't very familiar with giving themselves injections or parents who have to give their children injections. So, but normally I've found that most of those anxieties are short-lived. A couple times they persist, but most often they're short-lived. Child life is usually a great help if available. And I think really those are the big things I want to discuss during that presentation.
All right. Would Aaron or Andrea like to add their thoughts?
I would. And I think one of the first things that Mandeep, you had said, which is a really good point, is having that information available about the financial cost of what it might even look like before you go into the room, I think would just be, because we already know that what we're going to be recommending at some point. Just having that as an answer in our back pocket, I think would be really good. What I think the unique part about pediatric work is, especially with shared decision making, is the spectrum at where somebody can be at, right? When we talk about adults and making a decision, we usually have, ways that we approach that. But with children, it can be so different based off where they're at in their life, right? Are we talking about somebody who is somebody who's 10? Are we talking about somebody who's 16? And one of the questions I would really like to ask the patient first is, what has this been like for you in your decision making along the process, right? If they have come to this point now, then they have been dealing with asthma for some time. And I'm curious as to what it's been like for them and what their approach has been so far. And is that something that we need to try to course correct in our own treatment with them and say, you know what, we're really going to try to make this about you. So it gets really interesting as we start to add that dynamic of not only dealing with a patient, but the patient and now their caregiver, and then trying to teach the patient trying to advocate for them to be, autonomous in making their own decisions. I'm glad that Mandeep had talked about the subcutaneous self-injections, because that could be something that we really present to, the patient as this is going to be something that you're going to be in charge of. And I know that adherence is something that we really talk a lot about in trying to make sure that patients are adherent to the medications that they have been given. And I know that Andrea is going to really help us out with some of that. She has some great tools for that I know she'll share. But if we're really trying to look at adherence, then maybe if somebody is a teenager and they're looking at a little more autonomy, what would it be like for them to have something they can inject themselves and actually make them in charge of it? We might see a better adherence along that line. I think also Mandeep was talking about some different ways to help with needle phobia. And I think the big takeaway from what he just said is there will be some anxiety, but the majority of people will get better with that anxiety. Only at the end of the bell curve, we'll see folks who really have a hard time with the anxiety of getting over that. And there are some really great interventions that can be used when people are on that end of it, such as systematic desensitization, which is a technique used in cognitive behavioral therapy, in which we follow along a series of interventions that help people become familiar with what the anxiety triggers are and to help them approach those in different, better ways. Also, and hypnosis was mentioned as well. And as a therapist, I have worked with some patients who have gone through hypnosis. And I think lots of times people don't understand really what hypnosis is. But what it really is helping somebody reach a relaxed state. And that's really what we're trying to do with somebody as they're going to get an injection is, how can we teach you this skill that can help you to reach that relaxed state? So when you're preparing for this injection or preparing for the time after the injection, that you can help self-soothe and work through that yourself. So those are some big takeaways, I think, is, really trying to find out where the patient is, find out where the caregiver is, have some answers in our pocket, and then be able to give them some suggestions or techniques that can help them if we decide that an injection is something that we're going to do. I see we have some clinicians on board. I'd love to hear some other people's thoughts as we move forward, about this in their own experience, and perhaps we can take some of those away as well.
That's great information, and thank you for you and Dr. Jassal, because I love how we can work as a team and really help these patients with asthma. And usually by the time I'm working with someone, they've already been diagnosed, they've been prescribed, and then I'm following up in our asthma home visit program, and they're not doing anything that's been prescribed. And so really trying to dig deep and asking them and say, well, tell me a little bit more about that. And so, and also normalizing, and I'll ask them, well, about how many days a week do you remember to take your inhaler? If you're like me, I forget a day here and there. And really for the average person, they may take it 2 or 3 days a week, and they'll say, well, I take my controller 4 days a week. So you're getting to the real answer of what they're really doing, and that helps guide you. And then you talk through, well, what's holding you back from that? Is it cost? Here's some of the things that when I'm helping people, these are just some of the most common things that I find. Either they feel like they don't need it and they feel like their asthma isn't that bad. Then we'll review what their asthma control test score is. It's a 9 or something. We'll talk about, can they afford it? Oftentimes we help them get to a federally insured clinic where they have a kind of a sliding scale program and help them to be able to afford their medications. And when we're talking about biologics, when it gets to that point, we talk about what is it that you can't do that you'd like to do because of asthma. Well, I'm on the soccer team, and I'm on the bench half the time because I can't keep up with everybody. And so we start talking about how it's really impacting their life. And when we talk about biologics, we just normalize it. Say, well, it's the 3rd Thursday, I'm going in for my shot. This is what I do. And funny enough, I work with a lot of adults that are still afraid of the needles. And we're right in the middle of doing our COVID vaccine clinic. And I have a lot of people that come in and they're just clenched and they're, about to pass out. So I have to talk them through that and say, well, why should good kids have all the fun? You should be able to get a treat. What are you craving? What do you want after this? You want to stop by Starbucks? Do you want to go get a shake? You want a cheeseburger? You need a reward for doing this. And I said, look, there's 2,000 other people here and they're all in the same boat. And I said, it's quick, it's over, treat yourself when you're done. So there's a lot of different ways, and it really depends on the person with that shared decision making is what's their currency and what do they need and how can you encourage them to be able to reach those goals. So a lot of tweaking as you go along.
Thank you, Andrea. Thank you, Erin. Like Erin said, do we have any suggestions from the group as to what you do for your shared decision making conversations?
Where I work, I'm specifically pediatrics. In our area, when we're talking about with patients, especially those who I'm seeing in the hospital that are hospitalized, so we know that they're, at that time, they're in poor control. And a lot of times when you look at patients who are in poor control, it's not just the rhinovirus that got them admitted, although that's what they want to say all the time. It really is all the factors of that, led them to not be well controlled before the child had the virus that caused. So we have to kind of deconstruct that whole picture for them and really explain it to them about the control and how that made the difference for the impact of the virus. And so again, just trying to re-educate them at every opportunity of the pathophysiology in with using health literacy in their terms, and going over the types of medications again to re-educate them. And then, as Andrea said, when you find out, and Erin said it, when you find out what barriers they have, it's just, their lifestyle is, such that they can't remember, the child is in split homes, all of these things, they do have to be addressed. We can't just write it down in our note. We have to really, pull together as a team. And, even for the parents and as well as teenagers, I always ask them, what is something, say if it's a twice a day medication, which majority of ours are for inhaler medications, what is something you just normally do twice a day and don't even think about it? You just don't think about it. And, people always say, hook it up with brushing your teeth, but you'd be surprised, kids don't brush their teeth twice a day. So it's not something we can really always do. But if they do, and they're vigilant with it, we talk about putting it there. But something, like if I see the teenager wears glasses, I say, do you take your glasses on and off night and morning? You put them back on. If you could set up something right where you have your glasses every night and every morning and put your inhalers next to that, it's something you don't even have to think about, because you don't go to bed with your glasses on your face. You always take them off. And I had one boy, the only thing he did twice a day that he could come up with was he takes his sneakers on and off. So we put his inhalers by his sneakers, and that worked for him. We had community health workers who helped set him up a nice little station for his sneakers and a little cubby for his medication, and that seemed to work for him. So you have to get a little creative with these families and see what works for them. We might say morning and night, but maybe it really has to be breakfast and dinner that they take their medication, because that's where the parent is. Whatever really works. As far as the biologics, especially in the younger age group, needle phobia is a big concern. The parents will a lot of times not even want to talk about it. When the same thing with immunotherapy, they don't want to talk about it because it's about the needles. And so we have a program in our hospital and probably in most other children's hospitals for taking care of this with IV insertions, where we use topical numbing creams, such as like a lidocaine or Emla. And we have had to use that, or talked about using that as an option, or using the ice and having the child be in control of putting the ice on their arm before they get the injection, and then being able to hold on to their Band-Aid or whatever they can do to be involved and feel they have some control. The types of environments that we do it in, not rushing them because their anxiety is really high. You don't want to get them in the room and have them have a complete meltdown and have a traumatic experience right from the start. So we do have, in the hospital, we have Child Life, but in our outpatient offices, we don't have access. So I wish we did, because they are a valuable resource for us. But in the outpatient office, we don't necessarily have that. So we try to incorporate some of their distraction techniques One of the ones I really enjoy working with kids, especially if they have to get injections, is something called kaleidoscope therapy, where the children have literally have a kaleidoscope that they focus and they look in while we're getting ready and while we give them their injections, and they continue to focus in on the kaleidoscope. So it's just, a diversional activity. But, I think with the pediatric population, you have to really incorporate a little bit more things and pay attention to those things about their lifestyles, because you're dealing with the parent and the child lifestyle, not just the adult patient.
Thank you so much, Lisa. I love the kaleidoscope. That's really cool. All right. Do we have any other questions or suggestions from the group? Dr. Jassal, do you have anything you'd like to ask of our group today?
I think one very interesting point that was brought up by Lisa, and just as a follow-up to that, especially given the discussion about biologics, was when Lisa had mentioned about the need to continually educate and to inquire about how we can maximize adherence. One part of the education component beyond inhalers is when to introduce the conversation about biologics, especially those who are poorly controlled. Do you do it right away? And do you bring it into the conversation when you start talking about you should get better controlled on your inhalers, and here's some strategies for that? Do you introduce it then? Or should you delay and give the adherence a better shot? So when do you do it, and how do you do it, especially in the context of this shared decision making about what families want from that conversation?
I find it interesting that some parents are actually bringing it up because they're seeing it advertised on television. So it does bring into the conversation, some of that information. What I'm seeing with our team is if we have those patients who are categorized severe persistent asthma and have a lot of risk factors that we already know from the beginning, once they're getting into that age group category where we would consider the therapy, they do start the conversation. It's not a conversation we have and then right away start them on the medication. This is something that they're introducing and having almost like little rollout conversations every time they see them. I think, like you said, Dr. Jassal, talking about them as a team approach and saying, okay, team, this is what we've tried. This is this recipe that we've tried. We've tried this recipe. Now we're, these ingredients maybe need to be modified a little bit, let's see what else we have. And then discussing it, maybe giving them some information to review on the medications and things like that. And then, it might take, 6 months or so before we actually have a more serious sit-down conversation. But it's something by that time they've heard a few times.
Another thing too that I think helps is putting it in perspective. So I may have mentioned this in the past, but all my kids had severe asthma. We're in the hospital 12 times. We had 2 ICUs. So when it was time to start allergy shots or the biologics, I said, you guys, this is going to be a piece of cake for you. I said, you know what it's like when you get your IV. And I said, this is going to be a quick pinch and it's done. And they're like, really? And so, it's so important to get the parent on board instead of, if I start to panic and if I start, immediately the child looks to the parent to see what the parent's reaction is. And if you've got these parents that are panicking and have this look of fear on their face, and like, it's fine. You'll be fine. It's a little pinch. We'll just go in once a month for your biologic. It's way better than being in the hospital. And same thing with allergy shots. We would normalize it and say, okay, hey, it's Tuesday. I'm going to pick you guys up after school for shots. Okay, hey, today's Friday. It's shot day. I'll pick you up. So just normalizing it and then letting them know that a lot of other kids are doing the same thing. Maybe not their friends. With my kids, nobody was as bad as my kids around here. But there were a lot of other kids in the clinic that were. A lot of other kids that were really struggling. So letting them know that it can be very normal and they're not the only ones going through this. And speaking of that, I just had a thought. Once COVID's over, when we can get back to how things were a little bit before, there are a lot of asthma camps in the summer. And I will put some information, Ashley, I'll send that to you. They have them all over the country. Some have scholarships. And it's great because each of the asthma camps, it's a safe way to let kids go away. And there are respiratory therapists there, there's doctors, there's asthma specialists. And all the kids are in the same boat. They all have allergies. They all have asthma. They've all been in the hospital. And it's a great way for them to make connections with other kids that go through the same thing they do. So I'll send the information to you.
Thanks
I
so much,
agree.
Andrea.
Andrea, I agree with what you said about the parents' reaction. And that's one of the things that we have seen. Because as you said, if you introduce this to the parents and the child is sitting in the room, even if they're looking at their phone, you know they're listening to everything that's happening. And if the parent immediate reaction is, oh, that's given by a shot, he'll never take a shot, you know, and so that right there formed the whole opinion of the whole family. So sometimes we'll ask the nurses in the office, can you take Johnny down the hall and get him some stickers and get him something? And then we'll have the initial quick chat about immunotherapy or injection type medications or something of that sort with the mom. So we get the immediate reaction of the parent instead of the child being in the room also getting the immediate reaction.
That's great. Thank you, Lisa. All right. Carolyn writes that there is a camp in Atlanta for all health problems. That's really cool. That's great. Thank you, Carolyn. We will definitely add that to our resource center. Absolutely. All right, we are a little over halfway through, and of course, we have Lisa's case from last week. Lisa, do you want me to just share it, and maybe you can kind of give us a quick refresh, and then
Sure.
we can do the
Sure.
the primary question that you have, I guess. Where would you like me to start?
I think just to refresh, this is a 6-year-old male who we've known since he was a toddler. And he's been, as you can review on here, he's had multiple hospitalizations. He's categorized as severe persistent asthma, but also has comorbidities of severe allergies, reflux. He's got eosinophilic esophagitis. His labs have always been very concerning for us because he is in the extremely high category for IgE levels on many of his food allergies, as well as his total IgE. His maximum total IgE was over 35,000 at one point about 2 years ago. And now he's running at around 10,000 still. His eosinophil count, I believe, was at one point over 600. Now it's a little under 500. He's atopic. He's got comorbidities. He has high risk with multiple courses in the past of oral steroids and hospitalizations, including ICU admission. He was intubated when we first met him as a toddler. So he's always someone that our entire team has concern about, and he's one of those little boys that if we haven't seen him in a while, everybody's concerned about even mentioning his name, because if we mention his name, what's going to happen. He's going to wind up in the hospital. So we all look at each other like, don't say the name, don't say the name, But he has been through our pulmonology team and continues to be, monitored and treated with the pediatric pulmonologist. Our allergists and immunologists follow him closely. He's been evaluated by infectious disease, gastroenterology, and he's had genetic testing for both cystic fibrosis and hyper IgE syndrome. So he wasn't eligible for Xolair therapy. He was, when he was 6, he's now, I think I made a mistake. I think he's like 8 now. So when he was 6, we were looking at Xolair therapy, but because at the time his IgE was 35,000 and the risk for anaphylaxis with this boy was of big concern, we didn't go that route. We were able to initiate last year Nucala for him safely within a pediatric procedure room in the hospital, but then COVID came and kind of scared the parents, and they didn't come back for that therapy after 2 doses. And I will mention, we also have quite a psychosocial history for this family. From day one, when I met him, he was actually placed in foster care because there's a lot of issues within the family. He did pretty well when he was in foster care for about 3 years. But then when he's back with his family, at this point, they've been homeless for about 2.5 years, living in a motel, all in one bedroom, 4 adults and this boy in one room. There's smokers all over this shelter. Parents themselves are smokers. Our Child Protective Service Agency has been one of our partners and involved. The school nurse is fabulous, and she's been involved. We've had community health workers and home care nurses. We've really utilized as much of our resources as possible. So at this point, it's actually, I believe the next step that we were looking at was his other partners, our other partners, which is dermatologists, is they're considering to add Dupixent because his atopic dermatitis, his eczema is really severe also. And because it's not approved for asthma at his age, we didn't have that on our consideration, but we have fingers crossed that if he does start this therapy, we may actually have a benefit because of his mixed allergic type asthma, that maybe we'll have some benefit because of his eosinophilic phenotype also. So anyone have any, I told my team that I'd be discussing him again today and bringing back any ideas or thoughts that anyone else had that maybe we just ourselves haven't, sometimes you need a fresh look.
Thank you so much, Lisa.
Lisa, it's a very challenging case. I mean, we could talk about it just on the medical components alone. I will talk a little bit to the medical components, but there's so much of the psychosocial history that I think plays such an interesting part. I think if we talk about the more immediate things about getting the kid under control and getting him a better life, one thing I thought was really interesting, and maybe you could clarify this. You said that when he was in foster care for 3 years, he was doing okay. And it's only when he went back into his home setting when things were under poor control?
So when we met him, he was a toddler, and I met him in the ICU. He was intubated, and it's one of those cases that you just can't forget, And so when I walked in and I met him, the story was that in the middle of the night, this was his first episode of an asthma episode, and I think he was like 14 months old or 16 months old. But in the middle of the night, he had an acute respiratory distress, and he was taken by ambulance to a community hospital, and then they sent him to our higher level hospital, Children's Hospital. At the same time, when I'm speaking with the team, the residents, I was told that his mother at the same time had an acute event, and she was sent to the community hospital, and she was intubated in the community hospital. So my red flags went up all over the place, and I asked everyone, so did anyone check out to see what is going on here, what's going on in the house? What was mom or whoever doing in the room? He was supposedly sleeping on the pull-out couch in the living room with the mother. What was going on? That both of them inhaled something and wound up in acute respiratory distress. So needless to say, there was an investigation, and it was found out that mom was doing some type of drugs at the time, and the child did inhale them. They actually did urine levels on the child and stuff, and that's where CPS initially got involved. And from that point on, he was taken and placed in foster care. So he was very little. But when I met him, he was literally crusted over, covered with eczema from head to toe. Barely could see a slits of his eyes. All he did was moan and scratch, and he was very thin, and it was tough. When he was in foster care, and we had a foster care parent, followed the diet like to the T, followed taking him to follow-ups, all of that type of stuff. He improved. His skin got better. His asthma was under better control. Things really leveled out. And, the way our systems are, things started to change, and mom went and did her parenting classes, which was great. But then, they don't just give them back for part of the time. They kind of give the child back. And so once the child went back into the home, and, mom did what she could do, I guess, with, what she had for her resources. For a while, he was, he kind of wavered and did okay, not okay, okay, not okay. And then all of a sudden, school age, he just did poorly. He was missing so much school. I was constantly getting calls from the school nurse saying the mother sending him to school with food that she knows he's allergic to. The nurse has to keep taking the food away. The nurse went as far as going shopping herself and was making him food and shakes in her office to feed him. I mean, everybody really is vested in this child. And it just happens to be one of those really poor social situations. And even since he's been in the shelter, you know, we've called CPS a number of times to please follow up, keep an eye, look at what's going on, you know, and we get a lot of reasons why, you know, they're in this situation, they can't get any other housing. We've tried, we've written a million letters to get them other housing. It's a bad situation. You know, this kid is in a bad situation, and you know, we have a little saying that we say sometimes, you know, children like this sometimes need an acute parentectomy. And this is one of those situations because he's really, you know, and we would never want to do that. We'd never want to take a child away from their family, but it's just a bad situation. The older he gets, of course, the harder it would be to do something like this. So it's really, that whole situation makes it really tough. And we're just grateful every time they do come for a follow-up. You know, we're always calling ahead. We're always reminding them. We're asking if they need transportation set up. You know, we really take care as much as we can for them. And mom knows too that one of the things that would have us call yes again is if she didn't show up for at least follow-up appointments. She's been okay about following up for that, but that doesn't help us change the environment that he's living in. So we know he's living in a high-risk environment. Cockroaches, dust, smoke, that we can't change anything about that. So therefore, we're always looking for what can we give him as therapy to help him, you know, to tone some of this down and tolerate the lifestyle that he's in.
Lisa, what a difficult, complex case. And I think, Mandeep, as you said, we can talk about this for, you know, at length in all the three biopsychosocial levels that you want to go to with this.
Right.
You know, and I think one of the things you had said, Lisa, earlier was, I think I would really focus on perhaps educating the child as well. You know,
We definitely do. Oh, yes.
Just that continuous
Yes.
reinforcement of the education for him. And even, you know, perhaps as he starts to get older now, so he's 8 and starting to advocate for himself about knowing that if being in an environment where people are smoking or if being in an environment where there's a lot of dust, you know, advocating for himself, saying this probably isn't the best environment for me. I'm going to go, you know, and try to encourage him to, you know, to start, because this is going to be something that's with him for his whole life.
And that's what we do every time he's been admitted. We have Child Life who works very closely with us. We have some, you know, child-specific activities that we do with him. I actually created an online, and I'll share it with you if you're interested. I created with students at our university an online asthma trigger house game that you can actually move through all of the rooms in the house and you find the triggers, and it talks to you about the triggers, and then the triggers disappear, and it's kind of like a sim game, you know, where you walk through. So we use that with him. But it's interesting how much you know, influence the family's how do you say it, behaviors and their attitudes about medications and excuses that we get. We hear the same thing from the child that we hear from the parent, you know, from the parent, and he doesn't really budge too much from that. And many a times he's one of these children who won't answer a question without looking directly at his mother. So you know what I'm talking about, that protective type behavior. So they're very much like this. And you know that behind the scenes, they're having lots of conversations about keeping, you know, everything under wraps. So he's under, the other thing we're concerned about is we all know the stress level for anyone with a chronic health condition can just make the health condition that much worse. And this boy lives under a chronic state of stress. So it's a tough one, but you know, one of the things the doctors were asking me is, have any of you ever dealt with a patient with an IgE of, like, you know, this level, and what other areas? Because our immunologists, you know, we tried to send him to, we're in New York on Long Island, so we tried to send him to Mount Sinai, you know, the Mecca for food allergy and this IgE, but we can't get the parents to take him there. So that's tough because we have a great resource in New York City, but we can't utilize them. And they don't have any satellites out by us. We've been on the phone with them. They're the ones who suggested do the genetic testing, which we already were going to do, but they, you know, confirmed that. But they hadn't had a case kind of this way either. So we'll keep plodding along and staying partners. The docs will, tease me that, how many times I've said, I'll take this child myself. I'll take them to my house, I'll just let me have them for a little while, So.
Lisa, I mean, I can speak a little bit to the medical component, and I've never seen an IgE this high. This is extremely remarkable and frightening at the same time point. So I totally understand how challenging this is for your colleagues. For me, when I run into these situations, obviously with this asthma-like presentation, I always look for the non-typical pulmonary-based source. And so, looking for an infectious source, if even doing a bronchoscopy, if possible, could always be helpful, or getting a reliable lower airway sample if you think there might be an infectious source. But there's a couple things that are really reassuring, is you're not hearing a story of recurrent infections, recurrent lung infections or ear infections or sinus infections.
No, viral infections, yes, for his past admissions, viral infections, but no, we don't have that's why we sent him to the immunologist and the infectious disease doctors, to really look at his, do a good immune workup with him and review his infections. And it wasn't found, even with the viruses, that there was anything that was a concern as far as his, having an abnormal immune system and response in that way.
Yeah, the other thing too is if this wasn't an older patient, but I'm not going to exclude it for children because I think all things should be on the table, is neoplasm or cancer. Certain types of multiple myelomas, for example, can present in very strange ways. Now, for this to happen in him would be a little weird, but like I said, don't exclude anything, especially in these situations. And usually when I get stuck, I always call my geneticists and I ask them what else is going down. And sometimes they do whole exome sequencing. So I know you might be thinking very targeted for the IgE, but sometimes there are some novel mutations we don't quite know. Sometimes imaging could help as well too. But one thing is that if you are concerned about especially if you have a good basis to it, like an autosomal dominant hyper IgE syndrome, there are some researchers perhaps at the NIH who do have newer protocols or newer research studies that they might be interested in this patient. And so this is just something to explore a little bit further if these situations arise. But I think this is another thing too that is really important, and this goes to what Andrea talks about in terms of the home environment. I've seen a couple cases of elevated IgE as a hypersensitivity reaction to inhaled products, specifically marijuana. We were concerned about. So these are things that I cannot explain such a high level. But could it be a contributory factor, especially if mom had been utilizing inhaled products before? And is there any other constant exposure this boy is exposed to? I don't know if there's any other environmental or home environmental issues, but it is really interesting to see this. And especially if the changes in those levels correspond to changes in environment.
Right. Yeah, and we absolutely agree. Like what we really feel it's a compilation of what he's inhaling, what he's touching and exposed to, what he's eating, because we know that the mom is not actually staying, adherent. And I know he's got a very strict diet plan, but we've had him with nutrition. We've had nutritionists reaching out. Like I said, we even utilized community health workers that took her a couple times shopping. We've done all this. It's just so many barriers. And, then you have a kid who says, I want chicken nuggets and I want, this kind of stuff. And her ability to handle that is not so great. And so she says, well, what am I supposed to do? He wants his chicken nuggets. And so I give it to him, and so, we try to talk to her about every time he gets another dose of an allergen, it just keeps adding it up. And then and we did it like in a drawing and cartoon methods to show her how that affects his skin. And that's the other thing, she can actually see it on his skin. So she knows, and we use that a lot to say, well, that's the same thing that's happening internally in his esophagus and in his lungs and his breathing tubes. But she's a smart lady. I never have found health literacy wise that I'm having like a huge barrier, because she's illiterate or not understanding. It's just that whole other, and the father the same way. You know, there was a time when he was in jail and he's been back, so we've been back and forth with him, and they definitely are the type that can, you know, they're the ones who can tell you everything the right way, exactly how it should be done, how they're doing it is 100% right. But yeah, then we still have this, you know, little boy who is very, very short because of all the steroids he's been on. And, you know, at times he's, you know, in like the 90th percentile for his weight, but he's, you know, on the very short side. So we talked to her about that and the signs of, you know, the side effects of using these higher strength, you know, oral steroid medications so often. And interestingly enough, like I had said, with the year of COVID, I don't even want to talk about it, but we've had a much better year for him. He's been home now. For most kids being home, you would, you know, you understand, but for him, we were very concerned because home means him living 100% full time in this one room in this motel and being exposed to things. But he actually did well. We had 2 encounters at the pediatrician's office within the year and 1 course of oral steroids. No hospitalization. So we, you know, we don't know. We don't know, but we're happy and that he's okay. And he did come and see the pulmonologist and the allergist once just recently. And that's where we're at. So he's right now going to see the dermatologist, and the plan that mom is agreeing to right now is going forward with biologic dermatologist.
Thank you so much, Lisa.
Thank you. I appreciate everyone's input. Thank you. I'll bring it back to my team.
All right. Well, thank you. I think that was all the summary that we probably needed. Thank you so much, Lisa. At this stage, I think we can probably move on with our post-test and housekeeping items. Next week is our final week. We will discuss managing injectable medications. So that's a little further into the biologic arena for those of you who have less experience with managing injectable meds. So do we have any volunteers to discuss a case for next week? All right, well, let's get on to our post-test polling questions. Everyone's favorite, of course. Question 1. Which of the following is important when deciding on which biologic to select for a patient with severe asthma? The patient's attributes and preferences, their insurance availability, using a shared decision-making model to discuss, or all of the above. And question 2. Which of the following is a benefit of shared decision-making? Patient satisfaction, improved asthma control, improved adherence to medication, lower healthcare costs, A, B, and C, or A, B, C, and D. All right, Dr. Jassal, how'd they do?
Once again, everyone did really great. So which of the following is important when deciding on which biologic to select? Absolutely all of the above are very important in terms of assessing both patient as well as provider associated factors. And number 2, which of the following is a benefit of shared decision-making? Absolutely all 4 of them are important in terms of assessment, including lowering healthcare costs. When you look at everything in terms of totality, in terms of the system as a whole, that also is a very important thing in terms of reducing hospitalizations and emergency room visits as well.
Excellent. Thank you, Dr. Jassal. Thank you, everyone, for answering those. Alrighty, like I said, we've got one more for our Echo Asthma Bootcamp. Thank you all so much for being here. Thank you to Erin for being here today. Echo clap to everybody. Echo clap, Lisa. Thank you so much. Looking forward to seeing you next week. Have a very, very nice week. Bye, everybody.